Thank you, everyone, for having me back here. I'm so glad to be here. I enjoyed giving the talk and the responses after that and just talking to people about questions. So my topic for today was just movement disorders update and also just what's new in movement disorders. It's a pretty broad topic. So I'm going to try to give a little bit of a sampling of different parts of movement disorders. I felt that talk about movement disorders won't be complete without videos. So there are some videos, and pardon me if some of them can be challenging to work with because, as you know, videos don't always follow our requests. Anyways, so here are my learning objectives. I want to review some common movement disorders and typical presentations and raise awareness for how do you make an early diagnosis and some practical management, both from a neurologic standpoint as well as from primary care standpoint. Also a little bit of emphasis on when to refer and what are the things that would suggest an urgent referral, and then some updates on the new treatments in each of these. I don't have any disclosures. So my talk is kind of oriented this way. I'm going to start with the phenomenology and then go to some videos and then more videos and then treatment options and then some recent updates and hopefully some idea about future directions. So phenomenology. So honestly, the one take home that should be from a movement disorders talk is it's all in the name. So when you name a movement, you almost invariably know what it is, and you can kind of start branching into the differentials the moment you name a movement. So oftentimes you will see us kind of going back and forth about exactly what movement are we talking about here. And for this, the purpose of this talk, I'm going to stick to involuntary and what we call involuntary movements. There is a whole functional movement disorder that is a total talk on itself. Involuntary movements are divided into paucity of movements, so lack of movements or hypokinetic movements, and excess movements or hyperkinesis. The term involuntary is kind of a term that is only seen in movement disorders, I think. It is where a movement is sort of semi-voluntary in that the patient can suppress it or the person can suppress it, but they don't have full ability to suppress it. And so it is not quite a voluntary movement. A good example is tics. Tics are considered what we call involuntary movements. Within hypokinesis, you have the freezing of gait, the slowing down of movements, and within hyperkinetic, which is the vast majority of the movements, it is tremor, it's chorea, it's dystonia, all movements that are excess of what we want somebody to do or what somebody wants to do. That's called a hyperkinetic movement. I will try and explain this in a pretty brief way because it is just the premise of why a movement occurs and why abnormal movements occur. So when you think of a movement, when I decide I want to pick up a cup, my cortex, the surface of my brain says, hey, this is the command I'm going to give you. And that command goes into what we call the basal ganglia. And the basal ganglia, oops, sorry. Where do I put the pointer? Maybe I can just use my mouse. Okay, so the basal ganglia is this portion of the brain, which consists of the caudate, the putamen, the striatum, subthalamic nucleus. This is like the motor programming and planning area of your brain. It has all these commands that are already pre-built, and then a command that is required gets stimulated, and a command that's not required gets suppressed. So when the cortex decides, hey, I want to do this movement, the main movement stimulator, the main movement pattern generator is stimulated, and the striatum then stops the GPI, which is the part of the brain that is suppressing all movements. So GPI is like your brakes. And so the main movement gets its brakes off, and then the surrounding movements gets their brake on. So this is what happens. The main movement is caused, and then the surrounding movements are suppressed. So that's how a movement occurs. So you can see these parallel slides here that talk about how what happens in the GPI and what is the movement. So if you want a certain movement, that's in blue, that becomes the actual movement in red, and then the blue surrounding area is suppressed. So in all movements, so you can basically use this phenomenology for every movement. For example, dystonia, what happens is the main movement that you want is kind of spilling into extra movements. So it's not just that one movement, but like the other muscles around it are also contracting. With chorea, it's not that the main movement is abnormal, it's the adventitious movements that are not suppressed. So you have the main movement, but then you have several other movements on top of it that are not getting suppressed that should have been suppressed. And tics is also similar to that, except there's a voluntary component to a tic. So this is a basic premise. And again, it's a very simple principle, but it kind of explains why certain therapies work and certain therapies don't work. Some important points before I go into actual videos and talks about particular movements. I think identifying the movement is half the battle. You identify the movement, you've already gotten half your diagnosis there. And also remember, a lot of movements have overlapping phenomenology. Just because somebody has a tremor doesn't mean they can't have dystonia. Just because somebody has chorea doesn't mean they can't have another movement. So oftentimes understanding that there can be more than one movement there also helps. And then most importantly, this is actually one of the CME questions. Some involuntary movements can be suppressed. So we always think of functional movements or like non-organic movement disorders or like somatoform movement disorders as things that are suppressible, but that's not true. You can suppress a rest tremor in Parkinson's, and you can sometimes suppress chorea also. So it's often other things that tell you that, hey, this is a real movement versus this is actually like a functional movement disorder. And then an abrupt onset of a movement disorder often cues you in for a functional process, which is like a non-organic process. But there is a caveat. There are young onset dystonia Parkinsonian syndromes that can present very quickly. You'd be surprised. I've had patients where they did a marathon or they ran a 5K, and then the next day they developed dystonia Parkinsonism. And you're like, well, how is that possible? But this is a genetic form of a movement disorder that can present pretty quickly. So that's the one place you have to kind of set aside the caveat that sudden movements are usually non-organic. And often the cue to a functional movement disorder, and I'm going to stress on this just here, and I'm not bringing this up anywhere else, is entrainability and distractibility. Oftentimes, the movement becomes worse when somebody's talking about it, and then as you distract them with other things, the movement gets better. That is pretty common in functional movement disorders. And also entrainability. When you have them do a task with the other hand, this hand starts to follow, which usually doesn't happen with the organic movement disorder. So that's some ways to understand, well, is this movement real or not? And lastly, response to medication can also cue you with the diagnosis. And I'll talk a little bit more in Parkinson's, especially. You want to show levodopa response for a Parkinson's diagnosis. So I'm going to try my videos and cross my fingers. So the first movement that I'm going to talk about is tremor, which is an oscillatory movement. So it's often a movement around a joint, and it's rhythmic. So by definition, it's rhythmic oscillatory. It can be because there's alternating contraction of the muscle or co-contraction. They're both contracting together. This is actually a video of a rest tremor. Yes, there you go. So it is the patient's hand is at rest, and it's a rhythmic oscillatory movement. It's very regular. And the moment they move the hand, it usually disappears, as you can see. And that's a pretty classic rest tremor. And then before I go to chorea, I want to talk a little bit about chorea. And each of these movements I'll talk about in detail. I just want to make sure you can look at the movement, see what it looks like. So identifying it helps you understand what it looks like in clinical practice. Chorea is another hyperkinetic movement. It's kind of the opposite of a tremor, honestly. It's an involuntary movement that is not rhythmic. It's irregular, purposeless, and there is no predictability to it. So you cannot tell what the next movement will be. Whereas with a tremor, it's a regular movement. So it's an oscillatory movement. So you know what's going to happen as the tremor progresses. Chorea, it's very hard. It's a fleeting kind of a irregular movement. It almost looks like somebody's fidgety. They're kind of moving a little too much. Oops, my bad. There. So this is hemichorea hemibellism. So this lady had non-ketotic hypoglycemia. And so you can see this sort of fidgety movement on the right side, and it's almost involving the arm and the face as well. You can see a little bit in the face, whereas the left side, which is a normal side, you really don't see anything. And chorea can be, usually it's a small amplitude movement, but sometimes it can be associated with athetosis. So often we put it together and say choreoathetosis because they can have a larger movement as well, not just a small fidgetiness. And then dystonia. Dystonia is sustained, repetitive, twisting movement. Remember, tremor was like alternating rhythmic. Dystonia is like a sustained movement. A good example is a writer's cramp. Like somebody's trying to write, and then their hand starts pulling and tilting, and then they can sometimes get a tremor. Dystonia can be anywhere. And the important thing to remember with dystonia that people sometimes forget is it can be very task specific. So that movement only comes on when you have a task, and otherwise it may not happen. So when they tell you that certain movements happen, you have to quiz them and check them in all those tasks. So I'm going to start with this one, which is from Lancet, and it's open source. And it's a pretty classic cervical dystonia. So the patient has twisting of their neck, pulling of their neck, and it's a pretty classic dystonic torticollis. And you can see as they try to go against that movement, they get a tremor. And then as they try to go back to the movement, they look better. I mean, they don't have as much of a tremor then.
Can you describe that?
And that's a sensory trick. So where they can touch their face and then they're seemingly able to correct the movement. And that's a pretty classic finding in dystonia. And this is actually a patient of mine that has what I call task-specific dystonia, which is the lingual dystonia. Just wanted to mention all of these patients have had their consent signed for videos for educational purposes. So he doesn't seem to have anything. And then the moment he opens his mouth, his tongue protrudes. It's a lingual dystonia. And it is basically very task specific in the sense that it doesn't even affect his eating. It only affects him when he's talking. So he's able to swallow, eat, maintain nutrition, but it's just when he talks, he gets this movement disorder. And then moving on from dystonia to myoclonus. Myoclonus is something I think most of you are familiar with, but may not recognize it as myoclonus. A good example is you're sitting in a boring lecture, and you're trying hard not to fall asleep, and then you get this like little jerk in your body as you're trying to prevent yourself from sleeping. That's a myoclonus. And some people have it when they're trying to fall asleep. That's called hypnic jerk or as hypnic myoclonus. It's actually pretty normal. And then a classic example in all of us is hiccups. Hiccups is a diaphragmatic myoclonus. But myoclonus can also be pathological. So myoclonus is basically this brief, sharp movement that's jerky, and it's very quick. So oftentimes it almost looks like a tremor if it's happening very quickly. The only difference is it's actually very irregular. So this movement that I'm going to, again, this is another patient of mine with MSA. I'm going to move to the middle of the slide, middle of the video, because that's kind of where the movement appears.
Front of you. Front of you.
So you can see her with her hands out, stretched out, and you probably already see there's some slowing down of movements, but you can see this almost like twitching of the finger that keeps going on. Like if you keep watching it, it's just this really twitchy movements of the finger. The side that it's happening on that's more obvious on the left side is actually the Parkinsonian side, and she had a multiple systems atrophy, Parkinson's subtype. And then some other hyperkinetic movement disorders. Remember, we're still in the excess movements phase. Tics, which, as I said, were the involuntary movements, basically can be any kind of movements. They can actually look like normal movements. They can be your shoulder shrugging, they can be your eye blinking, but it's just excess of normal. And there is suppressibility. By definition, they're usually able to suppress it. And they often will say, I have an urge to make this movement. If I don't make it, it's just going to get worse. And this, again, is from Lancet. So you can see, I don't have the video, but you can see she's actually like verbalizing as well. And there's these eye blinks, there's the facial scrunching. Some of these movements can even be normal day-to-day movements, just in excess and not required for that particular, whatever the task that they are doing. So that's how tics would look. Tourette's is where you have tics starting before age 18, without a secondary cause, and usually a combination of motor and vocal tics. And then this is the next movement that I'm going to talk about is ataxia. And there's a little bit of controversy on, well, is ataxia truly a positive movement or excess movement? The understanding now is it is probably excess and incoordinated movement. It's breakdown in normal movements with some adventitious movements on top of it, like a tremor or dysmetria. This again is a patient of mine with opsoclonus myoclonus ataxia. Unfortunately, you can't see the opsoclonus because the video is a little bit too far out when I'm at least this video is, and this was in pregnancy. So it's pregnancy-induced autoimmune opsoclonus myoclonus ataxia. And you can see she has a little bit of myoclonus too. You can see that jerky body movement, and then the wide-based gait, cautious wide-based, and when she turns also, it's a really wide-based gait. And it's a pretty classic ataxia. It doesn't tell you, one thing I want to make clear is, when somebody's ataxia, it really doesn't tell you if it's sensory ataxia, is it cerebellar ataxia? It just tells you, well, there is a balance disorder here. Further exam is what's going to define, is this coming from the cerebellum? Is it coming from like a sensory proprioceptive problem or not? And then hypokinetic movements. Some of you might have experienced this with your Parkinson's patients. The classic hypokinetic movement is bradykinesia, which is a required movement or required problem with movement for a diagnosis of Parkinson's. So somebody can have a resting tremor, somebody can have several other like hypophonia, all the other things with Parkinson's. But if they don't have bradykinesia, you really can't make the diagnosis. And bradykinesia is the slowing down of movement, but also not just slowing down of speed, but also decrement in the amplitude. So there's drop in the speed, drop in the amplitude. That's when you call it bradykinesia. And this gentleman had neuroleptin-induced Parkinsonism, and you can see instead of the big movements, he can try it, but then as soon as he starts doing it, he tires out and his movements get smaller and smaller. And that's classic bradykinesia. And lastly, freezing of gait. Freezing of gait is actually nothing but bradykinesia or akinesia in gait. This gentleman doesn't have Parkinson's, but he's got primary freezing of gait. And the classic symptom is they feel like their foot is stuck to the ground. They clearly define the syndrome by their symptoms. If you see this, you worry about Parkinson's, Parkinson pluses, PSPs, anything in the Parkinson's family. So you'll have to watch him just as he starts to walk and just as he turns, because after that, he seems like he's doing fine. Oops. Sorry. So he shakes it off and he's able to move, and then he turns and tries to turn. And then he's almost like his foot is stuck, he cannot move. And he kind of shuffles in that place for a little bit and then walks back. So that's a classic freezing of gait. And sometimes you have to kind of make it happen because it won't happen in straight walking. So you may have to have them turn a few times and then see. It's actually a pretty big risk factor for falls in Parkinson's. So somebody's saying they're falling, it may be good to check, is this what's happening that's causing them to fall? So I just want to label the most common movement disorders, and I'm going to talk about mainly these because honestly, the talk is too huge if you include every movement disorder that's possible. Essential tremor, which is the most common movement disorder, but it's actually not the most common that presents to movement disorders docs because our primary care manages essential tremors really well. And oftentimes, if it's mild enough, patients don't also want treatment for it. And then Parkinsonian syndromes, and there's an umbrella of them, and I'm going to focus on Parkinson's disease, dystonias, ataxia, and myoclonus. So for the purpose of this talk, I'm going to stick to these 5. Essential tremor, it's an isolated action tremor. So you're trying to do something with the hand, it shakes, you keep your hand at rest, it's gone. It's often bilateral limbs, both hands are affected. Less than 4% of the time, it's one hand only. So if you see essential tremor in only one hand, and that's the first time you're seeing somebody, you really have to watch them closely because it is unusual for that presentation to occur. And it has to be present for at least 3 years. So when I see somebody with essential tremor or whom I think has essential tremor, early on, I do not make that diagnosis. I say essential tremor, but I'm going to watch them closely to make sure this is not emerging Parkinson's, because you can have an asymmetric postural tremor in Parkinson's too. There can be soft signs, like if somebody's had essential tremor for 20 years, they may have a resting tremor. But the difference is the resting tremor there is smaller in amplitude than the action tremor. So you have them put their hand out, they got this massive tremor. At rest, it's pretty mild. So it is a very mild tremor at rest and then much more in action. That should key you into, well, this is not Parkinson's, this is still essential tremor. And sometimes they can have ataxia. So people are often surprised when ET patients kind of over time develop balance disorders, but that's not uncommon. Even without medications, they can develop a balance disorder. And they can get a little cogwheeling because of the tremor, they can get a little stiffness. What they won't have is bradykinesia. So if you see bradykinesia, slowing of movements, reduced arm swing, all of those should point you into, well, this is no longer essential tremor. There's often a family history, and there's often alcohol responsiveness, which I ask very discreetly because I don't want to suggest that alcohol is going to help them. So oftentimes you say, well, when you are out socially, do you feel like a glass of wine or something will help you? The greater than 14%, what I meant is 9 to 10% of the population has some form of tremor by 65. So it's actually pretty common, depending on which studies you look at. And in the 80s, almost, if you look at certain studies, it's like 20%. So I guess it depends on like how you grade the tremor. If somebody has a mild tremor, if you're going to grade it, then actually the incident prevalence is actually quite high. There is a slightly higher risk for Parkinson's in people with essential tremor. So 3 to 4-fold, not a huge risk, but also the reason why I tend to watch my ET patients over time. And then I want to talk a little bit about DAT scan because I do use it sometimes. It is a transporter scan looking at dopamine uptake in the brain. It is a SPECT scan, except they've given a dye to attach to dopamine receptors. So classically, the scan will show this normal kidney bean appearance of the basal ganglia in patients that don't have Parkinson's. This is ET patients, this is drug-induced Parkinsonism patients, this is your lithium-induced tremor patients, Depakote-induced tremor patients. Usually the DAT scan's normal. And then in Parkinsonian patients, you lose the tail end of the putamen uptake and then eventually the caudate uptake. So instead of this nice kidney bean appearance, they start having the shrinkage in the uptake of dopamine into the transporter. So they get these dot-like appearances. So it's a pretty good visual scan. It's used in clinical trials. I use it when somebody's had refractory essential tremor, and then over time now they're developing a little bit of subtle Parkinsonian features, and I'm not sure. The reason I need to know is if we decide to do DBS, the place where we would place the electrode would be different if this were Parkinson's versus essential tremor. So knowing that diagnosis is important. The other place where I use it often is somebody that's been on a neurolep for a long time and now is developing Parkinsonism. It becomes pretty challenging because the neurolep could be making the Parkinson's more obvious, or the neurolep could be causing Parkinsonism. And usually in neurolep-induced Parkinson's, the scan is normal. The scan's FDA approved for two specific diagnoses, ET versus PD, and then DLB versus AD. So if you put in those codes for DLB versus AD or ET versus PD, it is covered. And then differential diagnosis demonstrate the spiral, which I think all of you know how to ask your patients to do. Often ask them not to rest their hand. You got this classic undulation of the spiral, which is a pretty classic feature of essential tremor. What is a differential diagnosis? Oftentimes, people with essential tremor need to be differentiated from what we call enhanced physiologic tremor. If you saw me later today after 4 cups of coffee, you will probably see tremor in me. And I think I'll see tremor in most of you if you had like 4 cups of coffee. So that's enhanced physiologic tremor. Similarly, if your thyroid function's off, if you have hyperthyroidism, if you're on medications such as SSRIs, SNRIs, you can get a tremor, which is an enhanced physiologic or a medication-induced tremor. That is different from essential tremor. It is non-progressive, firstly. It's a little more irregular and lower amplitude. And oftentimes there's a temporal correlation too with the change in the meds. So it's important to rule those out when you see somebody with an essential tremor. The one caveat I would say is lithium and Depakote can also cause Parkinsonism. So when you see people with tremor with lithium and Depakote, you kind of have to watch, is this looking like a medication-induced plain tremor, or are they having other features like shuffling gait and a few other things that make me worry about Parkinson's? Because with tremor with lithium, I mean, if it's not bothering them and it's a mild tremor, I don't usually try to ask to change the medication. I try to treat the tremor. But if it's more than that, if it's Parkinsonism, I do talk to their team to see if we could get them off the lithium. And then big caveats to essential tremor diagnosis, as I said, less than 4% are asymmetric. So somebody that's asymmetric and staying asymmetric kind of have to worry about something more. Leg tremor, isolated leg tremor is almost never essential tremor. It's very rare for it to be like, it's often actually emerging Parkinson's. A strong resting component. So the main place where you see the tremor is at rest. Again, probably not ET, probably PD, emerging PD. And then if there's a pretty severe gait disorder, like gait disorder disproportionate to the tremor, think of cerebellar processes because they can overlap as well. So that's about ET. Treatment options, I won't go through meds too much because I think a lot of you do this. Primidone up to 400 to 500. I have to say I get nervous at 350 because I do feel like people start having balance problems. If they're younger, I go to about 400 sometimes, but by then I'm usually talking to them about other options. Propranolol up to 240, topiramate up to 200, but honestly, most people don't tolerate topiramate that well because of the cognitive side effects. And ET has a bimodal distribution. So it's like younger age group and then past 65. So giving topiramate at high doses there becomes challenging. There are quite a few equipments out in the community now. There's the LiftWear, there is Steady Glove. There are a lot of equipments for tremor cancellation. There's also the Tremor Foundation actually has some links to these utensils and modifiers that can help them suppress their tremor. And then there's speech-activated devices for hand tremors. And then dressing assistance. The picture I have is a snap instead of trying to button. It's like just a snap for buttons. 2 important updates in essential tremor that I want to talk about. One is Scala Kick, or Cala Trio. It used to be called Cala Trio, and now it's called Cala Kick. It is actually a wearable device. It is meant to send stimulation to the median and radial nerve. It is a non-invasive stimulation of the peripheral nervous system to suppress the central tremor. So it is the mechanism is thought to be retrograde input into the sensory pathways and suppression of the thalamic outflow, cerebellothalamic outflow. It is very risk specific. So you have to ask your patients, well, this is your right or left wrist, because the band kind of fits based off of that. And you leave it on for 40 minutes, and then the suppression can last up to 2 to 3 hours sometimes. And the patient, acceptance of the side effects has been actually pretty reasonable. I've used it myself before I put it on my patients. It is like getting zapped, just like getting zapped. But again, you can control the amplitude and get to the amplitude that is most manageable for you and does not bother you for those 40 minutes. Its coverage is something that's been a little bit challenging. Medicare Advantage covers it. There are a few private insurances that cover it. They have a cash pay assistance. I've had a couple of patients try this instead of, well, once they've exhausted their medications. As you probably know, medications help only like 50% of the time with a tremor. So then this is an option, or if they have side effects to medicines, this is an option. If they're not ready for DBS, the brain surgery for tremor, then this is an option as well. DBS, I'll talk about a little bit more in Parkinson's, because that's kind of where a lot of the changes in how we are using DBS has come. But just remember, DBS is a treatment option for tremor. It's the placement of electrode inside the brain to stop the tremor in the thalamus. Focused ultrasound is the other one that's in the news. This is high frequency ultrasound. We've used ultrasound for lots of different things for a long time. We used low frequency for neuromodulation. We've used high frequency for lesioning for like purposes of brain surgery. But this is a more recent literature on high frequency ultrasound for specifically tremor, Parkinsonian, and essential tremor. As of December of last year, it's FDA approved for bilateral usage in thalamus for essential tremor. What essentially happens is this is an MRI guided lesioning of the thalamus. So the patient is basically put in an MRI suite, has a helmet, and has just a diaphragm that kind of protects against the heat from the ultrasound probe. And focused heat is applied at supra lesioning levels. So they basically initially heat that tissue based off of MRI localization. So they localize the thalamus VIM using MRI guidance, and then they heat that area to subtherapeutic threshold. So they heat it to the point where it's kind of modulating the tissue, but not burning it. And then they're able to see if the tremor is going to get suppressed, is the person having any side effects. And then once you realize that, yes, there's enough tremor suppression, then they go above the 44 degrees centigrade heat, and then they burn the tissue. So it's essentially a thalamotomy, except instead of putting a probe and lesioning or gamma knife and lesioning, you're lesioning with high frequency ultrasound. It's got pretty good data. I would say it doesn't have long-term data, but that's because it's a new option. But it is an option for people that are not candidates for DBS or can't get DBS or are concerned about DBS. This is the other option for tremor. One thing to think about is the skull thickness. Very thick skull, very hard to get the heating into the substance into the brain, into the thalamus. So oftentimes it ends up causing, oftentimes skull thickness will prevent them from getting the focused ultrasound. So they do CTs to measure the thickness before. So that's about essential tremor. Parkinsonian syndromes, as I mentioned, I'm focusing a lot on Parkinson's disease. Clinical diagnosis, need to have a tremor, but not necessary to have a tremor. So you have to have 2 out of 4 symptoms. One has to be bradykinesia. If you remember, bradykinesia is that slowing down of the movement, decrement of the amplitude. Your patient's not going to say they have bradykinesia. They're going to say, well, my arm feels weak or feels tired, and I feel like I have to command my arm to move, or my leg drags. That's often the symptom of bradykinesia. And what they call as weakness is usually slowness of movements. So that's the most essential feature. If you don't have that, you don't have the diagnosis of Parkinson's. In addition, you could have a tremor, and the tremors present 70% of the time, but 30% of the time it's not present. So just remember, absence of tremor doesn't rule out Parkinson's. Rigidity, which is the stiffness that is not velocity dependent, the sort of this continuous stiffness or in the muscle, in the limb, in the neck, in the leg would be the other diagnosis, and postural instability. So gait imbalance would, so any 2 out of those 4, with one of it having to be bradykinesia, would give you a diagnosis of Parkinson's. So when I see a patient with Parkinson's that I suspect has Parkinson's, you will see my notes always say Parkinsonism, because I still don't know, is this regular Parkinson's? Is this going to evolve into anything else? So you have to make sure there are no red flags. And remember, red flags can appear 3 to 5 years into the diagnosis. So there's a very humbling study that we discussed very recently that talks about how only 30% of the time we are sure that what we are looking at early on, like in the first year with Parkinson's, is idiopathic Parkinson's. And the reason being, it takes good response to levodopa. It takes absence of all of these red flags to be sure that this is idiopathic Parkinson's. And that can take up to 2 to 4 years for you to be comfortable with knowing that. Red flags being early dementia, early falls, postural instability, and then like gaze palsies, and then any kind of like alien limb or like sensory changes such as like tactile sensory stereognosis problems, anything that suggests there's more than just Parkinsonism, something else cortically happening. And then of course, no medications. Remember, antipsychotics can cause Parkinsonism, so just making sure they're not on any drugs. And Depakote can cause Parkinsonism. People forget Depakote does cause Parkinsonism. Reglan, promethazine. So remembering these medications that could potentially cause it. And lastly, robust levodopa response. So at least 30 to 50% improvement in symptom is required for idiopathic Parkinson's diagnosis. That's the other CME question. So you have to have the levodopa response to be able to say somebody has idiopathic Parkinson's. Otherwise, it would still be Parkinsonism. So this is just a table. You can look at the slide later. It's just looking at the balance of positive and negative symptoms. Positive symptoms and the absence of atypical symptoms would point you towards typical Parkinson's, whereas the more atypical, more red flags, then your kind of diagnosis leans towards the other side. That again, so remember we talked about the DAT, the dopamine transporter. The problem with Parkinson's is this loss of dopaminergic neurons in the striatum, and it starts in the substantia nigra and then the projections into the striatum. So because of that, when you give external dopamine transporter to attach to those receptors, you have fewer receptors. So that's why you see the shrinkage from the comma-shaped appearance. You start seeing the shrinkage in the receptors. So that is helpful in a diagnosis. It doesn't differentiate what kind of Parkinson's somebody has. It just tells you it's a neurodegenerative process. Could be Parkinson's disease, could be DLB, could be CBD, could be PSP. That's a clinical diagnosis. And you got to have good levodopa response. And by good, I mean like 30, 40% improvement in symptoms and up to sometimes 900 to 1,000 milligrams. So you may have to push the levodopa quite a bit high over a 24-hour time frame. So often I do 300 milligrams 3 times a day when I'm really needing to show response. Of course, you don't want to start there. You want to start pretty low. And then again, the red flags. If you're ever not sure and you're concerned, it is totally okay to try levodopa. It's been around for a really long time. It's a very safe drug. Most common side effects, nausea, lightheadedness, hallucinations. Most people tolerate it okay. If you start very slow, and I usually start half a pill a day for a week, half pill twice a day for a week. It takes me 6-8 weeks before I get somebody on 1 pill 3 times a day. But most of the times when I do it that way, I find they tolerate it actually okay. And I can see if there's a response at that point. What is new in Parkinson's? This is new in Parkinson's. There's actually one more thing that's new in Parkinson's, but it's only in an abstract in MDS. So I'll just talk a little bit about it. This is a skin biopsy for Parkinson's diagnosis. So you probably know the skin biopsy for small fiber. So if you have somebody that has small fiber, you can do a skin biopsy and look at the small fiber density. But what we can do now is, this is through CND, we can actually look at phosphorylated alpha-synuclein. Remember, the problem in Parkinson's is there's abnormal deposition of this alpha-synuclein, which is this abnormal protein that is inside the cells in the form of Lewy bodies. It's just not in the brain alone. It's in other parts. It's in the mucous membrane. It's in the skin. It's in the autonomic system. It's in the rectal mucosa. It's in the gut. So this study is the SIN1 study, which just resulted in April, and we only have abstract data on it, showed that if you were to pick small skin biopsies from 3 areas, C7, like right next to C7 in the neck, above the knee and above the medial malleolus, 2 out of those 3 sites are commonly done for small fiber biopsies. And you tagged this phosphorylated alpha-synuclein and you found alpha-synuclein in those areas, you have a pretty high sensitivity and specificity for a Parkinsonian syndrome. The sensitivity and specificity based on that 400 people study was close to like 95 to 96%. So it can augment your clinical diagnosis. One portion of the study was also looking at the pattern of how the alpha-synuclein was deposited, you could differentiate Parkinsonian syndromes. We don't have that data yet. I only have the data from just the actual specificity and sensitivity of the diagnosis itself. So at this point, at least, it can help you with the diagnosis. I don't know that we have enough data to say it reliably distinguishes the kinds of Parkinson's. Even more recent than that is there's the alpha-synuclein seeding amplification assay, which looks at alpha-synuclein in the blood, and it looks at specific phosphorylated forms. And that is not yet published data. It's in the MDS abstract. And that had actually pretty decent sensitivity, above 90% for Parkinson's, but a small study from one group. So I think we need to see the actual paper to see how reproducible that is. But that was in the news very recently as well. And it's a blood test for alpha-synuclein. So that would actually be even better than a skin biopsy in my mind if we can demonstrate very similar sensitivities and specificities. And then therapeutics, I'm going to be very brief on this because I don't want to lose out on time. Just circling the most recent medications that have been approved for Parkinson's. One of them, Kennewick, which is apomorphine in the form of a wafer, is no longer available. Istradefylline is a novel mechanism, alpha adenosine receptor antagonist actually, and it basically balances out dopamine. Adenosine and dopamine kind of work in parallel in the striatum. So the blocker, alpha adenosine A2 receptor blocker, basically helps with reducing dyskinesias and improving on time. The mechanism, the idea behind the mechanism for it came from actually caffeine, because we know that caffeine is protective in Parkinson's, and caffeine can help with motor symptoms in Parkinson's. And it works through the adenosine receptors. So the idea for that actually came from our literature on caffeine. And then the other drug that is new is Inbrija, which is levodopa in the form of an inhalation. So you're able to just have inhaled levodopa. It's very short acting. So it's helpful in like off times that you want to quickly act on when levodopa is not kicked in yet. And then there are two new drugs that work on making levodopa last longer. There is a slide on them, so I'm going to just let you read through the slide. I think you should be able to get the slides as well. Just remember that Kennewick is not available right now. And this inhaler is a powder. It's a capsule with a powder, and it's an oral inhaler. It's pretty good as a rescue inhaler. And then opicapone, which is a new drug that is similar to entacapone and makes levodopa last longer. And then the jejunal levodopa, which is not so new, honestly, but it is a therapy option for people that are not able to get DBS or are not candidates for DBS. It's intrajejunal cassette infusion of levodopa. So this is what it looks like. There's a GJ tube, and you infuse levodopa. There's a basal, and then there's a bolus rate. It has actually pretty reasonable pharmacokinetics and the very more predictable response. Remember, one of the problems we have with just regular levodopa is it just doesn't get absorbed in the gut. Somebody's gut slows down. The pill is still in the gut. They have food in the gut, so it just doesn't get absorbed. Protein affects its absorption. So jejunal infusion kind of bypasses that, so you can kind of have a better predictable response. So if you can see their on time, so this is the levodopa gel, their on time without dyskinesias was better by a few hours compared to just levodopa oral. And then the off time was also better. Why is it important for the on time without dyskinesia? Because if you're on but you're dyskinetic, that is still affecting your function, because oftentimes you have levodopa, but you have too much of it, and then the patient's moving too much. So that puts them at risk of falls. That burns a lot of calories, so they often are losing weight because of that. So an improvement in on time without making them dyskinetic is actually a pretty big deal when you treat somebody with Parkinson's. So that 2 hours is actually a pretty good value added for their time during the day in terms of on time. And then DBS, as you all know, it's brain surgery for Parkinson's. What we end up doing is we place an electrode inside the brain in a couple of different areas. For Parkinson's, we place it in 2 nuclei. We place it in the subthalamic, I don't know what you can see actually, subthalamic nucleus, and then we place it in the globus pallidus. For essential tremor, we place it in the thalamus. It is under anesthesia, framed surgery at Virginia Mason. There are some people that do it under MRI guidance as well. So you can have a sleep and awake DBS. We do awake DBS. And it has really, really strong data for improved outcomes compared to best medical therapy. So if you look at the first slide, which is neurostimulation, that's DBS, versus the slide, the graph that's next to it, improved on time about 4 to 5 hours without dyskinesia compared to best medical therapy. So there's solid, robust data for over 10 years on DBS. What's new in DBS, though, I want to talk about before I run out of time is now we have 3 companies that are able to give us electrodes that we can use and the programming that we can use. There's Medtronic, there's Boston, and then there's Abbott. And each of them has their own little things that help us program better. All of them now have much easier to use patient programmers. Medtronic has what we call brain sense. The lead that you place not only stimulates, but it also listens to the brain. So you can actually listen to what's going on in the brain in terms of their beta activity for where their Parkinson's symptoms are more obvious, or their gamma activity where they have more dyskinesias. And so they can actually put themselves in this brain sense mode and then click a button and then say what symptoms they're having. And so you can tell, like, this part of the day in this stimulation, this is what they had. And so you can adjust your stimulation based off of that. The next step or the next gen for this would be closed loop stimulation, where not only does the brain sense what's happening, but it adjusts the stimulation. So if they're dyskinetic, then lower the stim. If they are hypokinetic, then increase the stim. So that is the next gen. It's coming soon. This is data gathering for that purpose. And then Boston has this current steering where each contact has its own current. So you can kind of manipulate the current whichever way you want. So the advantage to that is you are less likely to start heating up areas that don't need to be heated up, and you're able to focus and use less current in the area you want to. And then Abbott also has directional programming. So you can channel your current in different directions. And Abbott also has remote programming. So you can have the patient at home and program. And all of them are working towards that. And I think the most exciting of all of this, I think, is the closed loop system, because when we see people and we put them in a setting and then send them home, I don't know how they're going to do. I just get feedback when I see them back, and I don't have that interval where sometimes they're doing better, sometimes they're doing worse. Having that closed loop, it would be invaluable in my mind for DBS patients. And then very briefly, what's kind of out there in Parkinson's, some things that have failed. Inosine or urate precursor based off of uric acid hypothesis in Parkinson's failed. Ion chelator failed. Passive immunization, negative study, but there's a larger subgroup analysis going on that shows maybe passive immunization can help. The phase 1 for active immunization, which is the PD03A, was actually successful and well tolerated. This is active immunization to alpha-synuclein to draw out antibodies to be able to remove alpha-synuclein. Protein misfolding, the Orchestra trial is phase 2 is recruiting right now. That's another interesting trial looking at misfolded proteins and clearance. And then there are some specific trials looking at GBA-associated Parkinson's, which has a slightly different prognosis. And so it's important to treat those people because they have Gaucher's-associated Parkinson's, so they end up having more cognitive issues. So there's a GCase enhancer. There's also, which is already available, Ambroxol. So that study is recruiting. And there are a few tyrosine kinase studies that failed, but there's one that's still recruiting as well. So there's a lot of new studies looking at disease modification, which is, I think, exciting. We want treatment for symptoms, but we also want disease modification in progressive disorders like these. And then dystonias, briefly, sustained repetitive contraction. So there can be co-contraction of 2 muscles. So for example, arthritis cramp, the hand is trying to flex, but then another muscle is trying to extend. So they often have this pulling, and then their hand goes back and forth, so they can get a tremor because of that. Remember, dystonias can be task-specific or they can be generalized. So it can be happening all the time, or it can be very task-specific. I have a couple of young teenagers with paroxysmal kinesiogenic dyskinesia, which is a form of and their movement is dystonia, where the only time they get the movement is they get up and run to go to do something and their foot twists. It twists for a few seconds and then it's gone. So if you just saw them walking up and down, you would never see the movement. You have to make them do that like that. They've been sitting for like 20 minutes, and then first time they get up, that's the only time they have their movement. So dystonias can be a little bit challenging that way, in that they may not happen all the time. So you really have to push the patient in that movement that will give them okay, thank you. You will give them the actual, the diagnosis. And again, there are different kinds of dystonia. There's lateral collis, there's torticollis, which is the standard one where they have a tilt to one side. Sometimes if you're not sure, have them walk. You can see the movements come out when somebody's walking. One important point here that I want you all to remember, I literally saw a patient with this yesterday, so I put it in there as well. Neurolapse can be associated with a kind of dystonia called retrocollis. So if you see a retrocollic, like head pulled back, neck pulled back, think of a neuroleptic as a cause, either at the time that you're seeing them or even recently. So it can be tardive. It can happen a few months later, and the exposure might have happened earlier. Again, clues to the diagnosis: have them walk, have them move. Often there's a dynamic component. Lower limb dystonia, lower limb tremor. Oftentimes you're looking at Parkinson's as a diagnosis more than anything else. And the picture is of Jess Antagonist, which is what I talked about, the sensory trick. We saw that in the video where he held his face and then he was able to fix the movement. They're not actually putting pressure. It's just a sensory input, because the idea behind why dystonia happens is there's this hyperrepresentation in the somatosensory cortex, and a sensory stimulus kind of corrects that to some extent. So they can have a sensory trick that can actually completely correct their movement. Like this lady has a very severe torticollis, and then with just touching her face, she's able to correct the movement. Treatment: botulinum toxin, DBS. We can do DBS for dystonia, and then trihexyphenidyl. I use trihexyphenidyl or Artane in generalized dystonias, not in focal ones. Botox works, and DBS for generalized works actually really well. Ataxias, balance disorders, you have to kind of figure out, is it sensory, is it cerebellar? So sensory exam is very important. If somebody has proprioceptive loss until their knees, more likely than not, it's sensory. If they don't have any sensory loss and they are wide-based, more likely cerebellar at that point. Again, diagnosis, differentials: is it degenerative? Is it autoimmune? Is it infectious? Is it para-infectious, post-infectious? Once you figure out the movement, then you kind of have the differentials in your brain at that point. Cues to diagnosis: cerebellar ataxias can be midline only. Sensory ataxias are usually worse in darkness because you lose the visual input. So oftentimes they're more unsteady at night or in the dark. So that's a pretty good cue. And then there is pseudoathetosis, where you have them stretch their hands out, close their eyes, and then the hands start kind of twisting or wriggling because they don't get the sensory input. They're not able to see the movement. Cerebellar can be midline or it can be appendicular. It can be one side, it can be bilateral, it can be just midline only. Midline cerebellar ataxia is classically alcohol-related, drug toxicity related, lithium toxicity related. Sometimes patients can complain of dizziness with ataxia, and their dizziness is partly because, one, their eye coordination is not okay. Second, they lose dynamic acuity, where they're walking and trying to read something, and that becomes very hard for the brain to suppress that VOR, visual input, and so they end up having dizziness when they're like just trying to move their head and walk. So you have to differentiate that from the vertigos, from the lightheadedness. And oftentimes, if their balance is not okay, you really have to think there is more than just maybe just labyrinthitis or like BPPV going on here. I put in the standard screening and treatments. Treatments are very diagnosis specific. The one thing I want to talk about, drug-induced balance disorders can last years, especially I've seen Dilantin causing balance disorders years after the exposure. So they've stopped Dilantin 10 years ago, and they're still, you can see the cerebellum is already shrunken and they're already having the balance disorder. So they may not progress, but they won't improve, unfortunately. Celiac is something to keep in mind. Celiac can cause ataxia. This is different from gluten intolerance, where here there's actually like an autoimmune response. And then just a brief mention, there's treatment for Friedreich's ataxia. I don't know that I have enough time to go over it, but it is a molecule that improves mitochondrial function and reduces the impact of the frataxin protein, and people, especially younger people on it, tended to have improved outcomes over the 48-month study that they did in terms of balance disorders and their ataxia rating scale. Myoclonus, very briefly, spinal myoclonus, subcortical, cortical. Cortical myoclonus oftentimes is epileptiform. So you're looking at epilepsy at that point. The subcortical myoclonus is what is a movement disorder. You can get cortical myoclonus that's not a seizure, example being the post-anoxic Lance-Adams syndrome of the hypoxic myoclonus. And then segmental myoclonus is another entity where it's just one segment, like one shoulder, one limb, one leg twitches. Causes, again, this physiologic myoclonus, as I talked about, falling asleep and trying to protect yourself from sleeping in a lecture. That's a physiologic myoclonus. Hiccups is a physiologic myoclonus. Hypnic jerk, which some patients complain of, is actually a very benign entity where as they're falling asleep or as they're waking up, they get this little body jerks. Sometimes it's bad enough to affect their sleep. It is usually benign, but you could treat it if you wanted. You could treat it with clonazepam. Sometimes SNRIs can make it worse. So just kind of seeing if they're taking an SSRI and an SNRI close to bedtime and making sure you move the timings may help. And then neurodegenerative, there's a huge list. I mean, obviously, CJD, prion disease is top on the list, but there are several other conditions that will cause a myoclonus. And then drug-induced, you should not forget drug-induced. The two things I want to point to in drug-induced is amiodarone, can cause myoclonus, and gabapentin. People forget gabapentin treats spinal myoclonus, but actually can cause myoclonus. I've seen people on gabapentin, they go into renal failure and they can't stand because their legs drop. They get negative myoclonus because of gabapentin accumulation from just renal insufficiency. And opiates can also cause, again, same in renal pathology, opiates can cause myoclonus, as can gabapentin. Treatment, most importantly, remove the offending medication, fix the metabolic change, and then you could do drug-specific Keppra for post-anoxic myoclonus. Depakote works for most myoclonic movements, actually. It's the drug of choice for myoclonic epilepsy, JME. And then for spinal myoclonus, gabapentin works. When in doubt, clonazepam works. So if you're not sure what kind of myoclonus it is and you want to treat it, you could use clonazepam. And then I just want to put this in there. There is a peripherally, so not all movement disorders are coming from the brain or the central nervous system. There is the palmaris brevis syndrome, which I think if you see it once, you will remember it for forever. It's basically a contraction of the palmaris brevis muscle, and all they have is this little twitching in that muscle constantly. And I've seen them referred for ALS, for carpal tunnel, for lots of different reasons. And all it is it's a peripherally induced twitch of the palmaris brevis muscle without any weakness. But sometimes it's bad enough that it can cramp, the muscle can cramp. And that's what it looks like. You see this like little divot. And it may not happen when you see them, but you'll see that divot in the muscle itself when you see their hands. And once you see that, you will not forget it, honestly. Treatment is just Botoxing that muscle really will help it. And sometimes it's the movement that they are doing. It's usually like a lot of hand gripping can trigger it. So kind of modifying the movement can help with that as well. So working with OT on modifying that movement. Future directions, targeted therapies for monogenic Parkinson's, like I talked about with the GBA-associated, LRRK2-associated Parkinson's, Parkin-associated Parkinson's. So targeted gene therapy is kind of the next gen for Parkinson's treatment. Advanced drug delivery systems. So we are looking at levodopa infusions. There is apomorphine infusion in Europe. So instead of having to worry about the gut absorption, you're bypassing the gut in other ways other than putting a tube in. So that's the next steps in drug delivery system. Closed loop Parkinson's treatment, which is basically not only you get feedback from the brain, but then use that feedback and modulate the stimulation. So you're able to complete the loop and the patient is changing their settings independently and you don't have to be there to change it for them. And then calcium channel blockers for ET, and then riluzole variants for ataxia, especially SCAs and Skylars, which has got approved actually. It's as I said, it works on the mitochondrial function and oxidative stress. And when to refer to neurology, and I want to leave this by saying, if in doubt, you can always refer to us. You can always call us. We are more than happy to help you figure out if somebody needs urgent evaluation, somebody needs modifications where they at that point. For any diagnostic clarity for any of these movements, feel free to refer. ET not responding to first-line treatments, anytime they want to consider any kind of device therapies. Any rapidly progressing movement disorder is enough for a movement disorders consult. And rapidly progressing can be weeks to months, actually. So if you're seeing a balance disorder that's progressing over months, more than enough of reasons to refer to movement disorders. Question of functional movement disorders or drug-induced movement disorders. And pathologic gait not explained by musculoskeletal reasons. So I do see patients that are ataxic, that have had musculoskeletal issues, but the issue is not enough to explain their gait. So oftentimes there's other things going on and it's very appropriate to refer to us. So when in doubt, please feel free to reach out to us and we're happy to see those patients. And I stopped exactly at 5 minutes. Okay, thank you. Questions? Yeah.
I do home health with this kid, he's about 21 years old, whose corpus callosum, I guess he was born, or they don't,
Agencies of corpus
right
callosum.
and left side. Well, anyway, he's really hard to do because when you turn him or lift his head up for range of motion or anything, he'll fight against you.
Mhm.
Opposite. And I keep wondering if there isn't any drug, and his mom doesn't want him knocked for a loop,
Mhm.
which I don't blame her.
Sure.
But if there isn't some sort of drug that just kind of relaxes his
Mhm.
muscles, because he's really hard, especially for us older nurses, to try to turn him and stuff.
No, makes sense. Makes sense. I'm not sure, honestly. I think that there's because it's almost there's a volitional component there is what I'm hearing. It's not like a rigidity. It's more kind of what we see sometimes in demented patients, right? The paratonia, they resist the movement. So same thing you can see with anybody with a brain, like an injury of some sort. So I don't know that I mean, you could always use a benzo, but I worry with your concerns about benzos will relax the muscle and they suppress benzos. Yeah, but the thing is, you got to kind of, with his cognitive function, you worry about, well, is he going to get, yeah. Mm. 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 Totally. Yeah. No, totally. Mhm.
Okay. Matt Rice, Family Medicine. One of my partners here about a month ago had a 2-year-old that suddenly quit walking and for 3 weeks couldn't walk and was sent to Spokane Children's Hospital, and they diagnosed her with cerebellar ataxia.
Ah, wow. Okay.
But then amazingly, I saw her in follow-up and she literally began to walk in my office and the mom was absolutely flummoxed and improved literally over minutes.
Huh.
Have you seen that? What causes that in a little kid?
I first, I'm going to say that my most challenging times in neurology residency was in children's because you can't get an exam from them, right? I mean, it's impossible to get an exam from them. I'd say I would have worried about, because if they're not able to bear weight on their legs, I would have worried about cerebellar ataxia in them as well, because you can have a post-viral cerebellar process. So you can have even any virus, especially in children, can cause cerebellar balance disorders. It can cause it in adults too, but more often in children. But how fast she recovered is a little bit odd for that, right? I mean, usually it doesn't recover that quickly. I don't know if along with that, she developed a fear of walking, right? I mean, once they start falling, they get a fear of walking. So even if they are not recovering, they may not quite be there. That's the only way I can explain it. I think she's too young for a functional movement disorder, but I would say probably post-viral cerebellar process. It's like an autoimmune, just like Guillain-Barré post-viral demyelination. It is an autoimmune process. And usually the prognosis is really good, especially in children. Yeah, but I'm thinking maybe she developed a fear of walking on top of it. And then your reassurance and your exam and your confidence probably helped her. Other questions? Anything else? Yeah. Mm-hmm.
Good morning. Thank you for the excellent talk. When do you refer to DBS?
Oh, good question. I'm sorry, I blazed through DBS. That's actually a really good point. So we've started doing DBS earlier and earlier in Parkinson's, in the sense that because we know that the best medical therapy is not going to give us the same effects as DBS. Having said that, I usually think about DBS when somebody has tried their medications and are starting to have motor fluctuations, which means they're on their medicine, it works, but then 3-4 hours in, it's off, and they're having to time their life around their medications. Years ago, we would wait until they failed that, in the sense they went there, they tried it, they got dyskinetic, they were round-the-clock medication. Years ago, we would wait until then to do DBS, but then that narrows your window of how long DBS is going to help, because DBS helps the motor symptoms. It doesn't help the cognitive symptoms. So if you wait too long, you're not giving them that window of opportunity where they can actually have improved outcomes and functional outcomes from DBS. So our general advice now is if they're starting to have motor fluctuations, so they take their medications, they either get dyskinetic or they are kind of wearing off, I will try a few things. I'll try a few things in terms of modifying meds, but I'm also already thinking of DBS. I'm talking to them about it, so they kind of have an awareness. If they are on their 3 times a day medicine, there's no wearing off, they're doing fine, then I don't see a good reason for DBS. The other place where I would do DBS early is if they have tremor, because tremor by definition doesn't respond that well to medicine. So even early on, they can have a pretty large amplitude tremor that may not fully suppress. And if it's affecting their function, I would think of DBS then because it works better than like medications. I think my time is done. And any other questions? Oh, yeah.
How often do you see panda syndrome? Because I have some suspicion on
Of
panda.
pandas in pediatrics, not in residency in pediatrics, not after that, because I see only above 17. Children above 17. So I haven't seen pandas
Yeah,
here.
because I've seen one like in their 20s, then I'm not sure whether it's panda, so I referred for workup. You want to
Okay.
explain to the audience what's panda?
So did you think pediatric autoimmune disorders associated with strep infection, but did they have like strep infection and then right after as an adult?
So he developed like URI symptoms in his 20s. Then there's all these ticks and all these things. So I'm not sure whether you see panda in adults because this ASO was pretty high and they said that he was fine before, then suddenly develop all those movements.
I mean, it is possible. It's more often seen in children as an autoimmune response. And most often the movements are tics. So it is possible, but I have not really diagnosed anybody with that in adulthood. More often after viral infections, I end up seeing chorea or ataxia actually. So that's what I usually end up seeing, but that's interesting. Is he responding to treatment or did he just get better on his own? Or
To children's. Then.
Oh, okay, makes sense. Any other questions? All right, thank you.